Hi there, my name is Konstantinos Linos and I come from Dartmouth University in New Hampshire, United States. And I'd like to thank the committee for inviting me to give this presentation. Here on my virtual background, you see the main library of Dartmouth University, which is a beautiful piece of architecture. I have no financial disclosures. Case one, a 58-year-old male with a history of growing dedifferentiated liposarcoma, presented with multiple indurated superficial papules at the perimeter of the skin flap. Here's the clinical picture after the main surgery, where you see here the patient has developed these multiple cutaneous papules. And this is the PANSS biopsy, where you see a diffuse superficial to deep dermal and subcutaneous proliferation of epithelioid cells, clearly malignant, with hyperchromatic nuclei and multiple mitotic figures, which are not very evident in these pictures. This proliferation was diffusely positive for MDM2 and CDK4. It was negative for cytokeratin and S100 and various other immunohistochemical markers that you see that are depicted here in this slide. So the best diagnosis is metastatic/recurrent epithelioid dedifferentiated liposarcoma. And here are the pictures from the deep main primary excision, where you see this background of well-differentiated liposarcoma, and here is the component of the dedifferentiated liposarcoma that were diffusely positive for MDM2 and CDK4. Liposarcoma is the most prevalent form of sarcomas in adults. It represents approximately 15 to 25% of all reported sarcomas, and it's been subcategorized in 5 distinct subtypes: a typical lipomatous tumor / well-differentiated liposarcoma, dedifferentiated liposarcoma, mixed liposarcoma, pleomorphic liposarcoma, and the new addition in the WHO 2020 bone and soft tissue book, mixed pleomorphic liposarcoma, very rare, which usually in the mediastinum of young individuals and behaves pretty aggressively. Differentiated liposarcoma is a histopathologic progression from well-differentiated liposarcoma, and both of them are usually located within deep soft tissue and retroperitoneum, but of course rarely can be seen in cutaneous sites, and that's why I'm presenting this case. Classically, there is an abrupt transition of a well-differentiated liposarcoma to a high-grade non-lipogenic sarcoma. However, you may have a gradual transition or interspersed areas of dedifferentiated liposarcoma in the background of WTL. What is the genetic signature of this tumor? We have a giant marker and ring chromosomes, and we have amplified sequences of 12q13 to 15 chromosome, where there are various genes located there, including MDM2 and CDK4. And this can be detected by fluorescent cytohybridization and immunohistochemical studies. A small percentage of dedifferentiated liposarcomas, and that's the reason why I'm presenting this case, up to 3% can show epithelioid phenotype, even in a diffuse manner, and this can mimic other entities, including carcinoma, melanoma, or mesothelioma. And here are a few examples of dedifferentiated liposarcoma with epithelioid features, seeds of diffuse proliferation of epithelioid cells. Here was in the colon, you see the background of normal colonic glands, or here a case with rhabdoid features. To make things even more complicated, dedifferentiated liposarcomas can have true epithelial differentiation, a true transdifferentiation, where you see here obvious gland formation and diffuse cytokeratin positivity. In terms of the superficial size, there are not many cases reported, about 150 that they're superficial, and about 44 they mentioned dermal involvement. And in terms, the most common subtype is pleomorphic liposarcoma, but there are only 5 cases reported of metastatic dedifferentiated liposarcoma, including the case that I just showed you. 3 of them were pleomorphic liposarcoma subtype and 2 of dedifferentiated liposarcoma subtype. Of course, first, when you're dealing with a malignant tumor, we have to define lineage. Are we dealing with melanoma? Are we dealing with carcinoma? Are we dealing with hematolymphoid lymphoma or sarcoma? And this that's the first step of when we apply immunohistochemical studies, because amplification of CDK4 and MDM2 is not by means specific to liposarcomas or sarcomas in general, but we can be seen here in melanomas as well, or even carcinomas, etc. And we thought this was a really interesting case, and we published it because, I mean, it was easy for us because we had the history, but you can imagine if we didn't have any history at all, and that was the first presentation, that could actually have a very broad differential diagnosis and potentially create some problems. So what is the molecular signature of dedifferentiated liposarcoma? It's obviously MDM2 amplification. SS18, SX1 fusion seen in synovial sarcoma, EWSR1, FLI1, and Ewing sarcoma, COL1A1 PDGFB or D in DFSP, and EWSR1, NR4A3 in extraskeletal myxoid chondrosarcoma. Second case, an 81-year-old male with a history of high-grade urothelial carcinoma had this papule on his left vertex scalp. This was the biopsy, the SAVE biopsy, where you see here a proliferation of epithelioid cells evolving the epidermis or arising from the epidermis, epithelioid cells with obviously malignant, kind of pleomorphic with hyperchromatic nuclei and increased mitotic activity. And these malignant cells were positive for CK7 quite significantly, CK5, P63, and they had focal to multifocal weak to moderate positivity for GATA3 here, and you see nice internal positive control of lymphocytes. And other virus markers were negative. So what is the best diagnosis? Actually, it is an epidermotropic metastatic urothelial carcinoma. And I, in this case, had identical BRAF mutation of the scalp and the primary urothelial carcinoma. Cutaneous metastases from malignant neoplasms are relatively rare, approximately 5%, and most likely to undergo cutaneous dissemination are melanomas, breast carcinomas, or lung carcinomas. From the genitourinary tract, renal cell carcinoma is the most common, where bladder urothelial carcinoma is quite uncommon, 0.85%, and specifically metastases from upper genitourinary tract are exceptionally rare. Epidermotropism is not actually very common. It's seen about 10 to 11% of cases in cutaneous metastasis, where vascular invasion is quite common, especially from non-hematologic neoplasms. Epidermotropic spread by urothelial carcinoma is usually direct extension from bladder. Distantly metastatic epidermotropic urothelial carcinoma, like in our case, is exceedingly rare. Urothelial carcinomas can show squamous differentiation in a significant percentage of cases, especially the higher grade they get. And people have used a lot of different stains, tons of studies trying to see which stains have the best, the higher discriminatory power to say if something is cutaneous metastasis of primary. Of course, nothing is perfect, and there you have to apply a set of stains, but one stain that has a relatively high discriminatory power is P63 or P40, but obviously in our case, it's not going to be very helpful because P63 it's positive in urothelial carcinomas as well. And this is and I studied quite a few years ago depicting that. Urothelial carcinomas can be positive for CK7 and CK20, but they can lose CK20, especially the higher grade they get. They can be only CK7. And traditionally, we know that squamous cell carcinoma, cutaneous squamous cell carcinoma is negative for CK7, but can express that. CK7 in a significant amount of cases. There's a nice case from Memorial Sloan Kettering, up to 22% of cases had CK7. And especially the higher grade they get, the higher chances were that you're going to get some CK7 positivity. GATA3 can be seen in cutaneous malignancies, including squamous cell carcinoma, about 88% in this study. And in the primary, the big study, when GATA3 stain came out, there shows GATA3 positivity in squamous cell carcinoma of the skin, about 81% here. However, there are other papers that show that they don't stain, especially when they get invasive, although this could be due to antigen retrieval, different antigen retrieval methods, etc., because actually the antibody clone was the same. So it can be positive, it cannot for squamous cell carcinoma. So, but in any case, it can create diagnostic difficulties with urothelial carcinoma when it's positive. So which of the following stain can be helpful in supporting the diagnosis of urothelial metastasis? I would say uroplakin. It's a stain. It's not super sensitive or specific, and it's not very widely available. But in the appropriate clinical morphologic context, it actually could be helpful in discriminating these tumors, although they are not really good studies looking at the subject of urothelial carcinoma versus squamous cell carcinoma. The others are incorrect options for obvious reasons are depicted here. Case 3, 55-year-old male with a subungual nodule of the right index finger. You see here a superficial and deep proliferation of spindle cells with collagenous areas and myxoid background involving the margins. The cells show predominantly a spindle-cell phenotype that look quite bland, and there's areas, as I said, collagenous, and then kind of abrupt to gradual transition to more myxoid areas. This tumor was negative for keratin, desmin, S100, SMA, but it was diffusely positive for CD34. So the best diagnosis for this tumor is a distal fibromyxoma. Was described firstly in quite a few years ago, back in 2001, and this is the biggest study so far with a very detailed characterization of distal fibromyxoma by Dr. Fletcher and colleagues. And it can have abrupt areas of between collagen background and myxoid areas, or it can be more, or the transition can be more smooth. The cells have can be more predominantly spindly or sometimes epithelioid with no significant atypia with interspersed mast cells, but they can show some atypia in some areas, or it can even involve the underlying bone. That's okay. RB1, it's a tumor suppressor gene, and it's mutated in, it's not very specific, it's mutated in a lot of different tumors in human neoplasia, but in terms of mesenchymal neoplasms, actually, it is characteristic, the loss of RB1 expression in a group of mesenchymal neoplasms, which is spindle cell lipoma, pleomorphic lipoma, typical lipomatous tumor, mammary type myofibroblastoma, and cellular angiofibroma. So that kind of the RB1 family, and now one more member has been added to this family, the acral fibromyxoma, which shows a loss of RB1 protein expression with the lesions of the RB1 gene detected by fluorescent immunohistochemistry. And this is the current case. We see nice internal positive control of the endothelial cells, where actually all the tumor cells were actually totally lost, and the FISH was positive for RB1 deletion. So which of the following markers expression has been recently shown to show loss of expression in distal fibromyxoma? As I said, RB1. And that was for me, and this is a picture from Dartmouth campus, and these are my contact details. And again, thank you for the invitation.